Thank you for talking with us and touching our heart. I do believe we need such a talk from time to time. It is more important than guidelines. Thank you.
Thank you very much, Professor Nahas. And hopefully, it not, you will never say goodbye.
It is my pleasure to introduce now Professor Hala El Wakil, which is one of the eminent nephrology in Alexandria, and she is very active every day and everywhere. She will talk to us today about an very challenging problems, which is nephrology and oncology. I hope that we will enjoy her lecture.
Bismillah ar-Rahman ar-Rahim. Thank you very much for this kind introduction, Dr. Abdel Bari. And I would like to thank the organizing committee, namely Professor Nagy, who invited me to deliver this talk. الحقيقة Professor Nagy meeting is one of the outstanding meeting all over the year. I try not to miss it all the time, but sometimes I miss some. But really, it is one of the fantastic meetings, not only in terms of science and education level, but also I feel love, I feel friendship, I feel a lot of nice emotions in this very nice team among our colleague in Mansoura University. Thank you very much for letting me with you. This talk was asked by Professor Nagy to deliver, which are about emergency and onconephrology. All of us face this lady with a lot of problems. She's a cancerous patient. She has a lot of emotions, a lot of sadness, a lot of medical problems, and come to you also to share you her renal problem. So this lady should have a good team, a challenging team, a cheerful team, as Professor Nahas just told us, not a sad team, and they should work together so as to pass this journey with this sad lady peacefully. So you are sometimes counseled for this lady when she's exposed to a radiology to take the contrast, when she is coming to adjust her dose in medications, when there is special situations in elderly, in young patients. So you are all the time a member, a good member or an important member as a nephrologist among this team, so as to pass peacefully during her journey. And the AKI is one of the very emergency situations in this journey. So let us discuss the AKI in cancerous patient. Is it rare? No, it is not rare, because we are confronted with this AKI in almost 50% of our cases, and around 1/3 of those patients may require renal replacement therapy. And among the top of the list of the prevalent cancers, type of cancers, come the renal cancers. And then come next multiple myeloma, hepatic cancers, and hematological malignancy. In a term of hospital stay and cost, When your cancerous patient have an AKI, the length of stay is more lengthy, the cost is more, the mortality is more, and the outcome is bad. So what are the factors that affect this outcome? A lot of factors come in front of us. First, the inadequate, when your patient is AKI, the patient with AKI and cancerous at the same time, there is a very difficult medications in terms of chemotherapy. The type of chemotherapy should be chosen in collaboration with the oncologist. The dose should be adjusted in cooperation. Again, the fate is not nice, because you are confronted with a high mortality among those patients for the multi-organ dysfunction, as well as the intensive care associated high mortality. Again, the drugs, the long list of the drugs have a toxic effects when they are more than expected in this AKI situation. And also the other side of the coin, when the dose is inadequate, and the cancerous, your cancerous patient does not take his proper dose because of the increased clearance for dialysis, by dialysis, for instances. So it is all the time, it is challenging. Who of your patients have a worst or a high incidence of AKI? So sometimes you have to anticipate who of your patients who may get AKI. If your patient is elderly, of course, it is more prone to have AKI. If your patient is a cardiac patient, if your patient is a CKD patient or hypovolemic patients, beside the bad malignancy, for example, the distant metastasis, the multiple myeloma and liver cancer and renal cell carcinoma, as I mentioned, because they are prevalent with AKI, as well as the hematological malignancy, especially with chemotherapy, especially when the dose is very high during induction. The causes of AKI in cancerous patients are many. As we teach our students, we all concentrate on the three main causes: the pre-renal, renal, and post-renal. But the subtypes or the etiology may vary in this special situation. In pre-renal causes, you have to put in your mind the volume depletion secondary to the nausea and vomiting, which are quite common in your patients taking chemotherapy, for example. The decreased oral intake secondary to the mucositis, which I experienced it very much with one of my relatives, that he couldn't swallow even his saliva. The polyuria caused by hyperglycemia or diabetes insipidus. The third spacing when there is ascites or something like that. The insensible losses when there is skin lesions, as mucosal fungoides, a huge tumor, losing fluid from these huge skin lesions. The hemodynamics mediated causes, as in sepsis, which is quite common in those patients. The congestive heart failure, the hepatorenal syndrome, the Budd-Chiari syndrome, and others. Again, the intravenous iodinated contrast agents leading to vasoconstriction leading to pre-renal azotemia, and also don't miss the abdominal compartmental syndrome with a huge abdominal tumor and ascites. And then the renal causes, the ATN, secondary to drug, chemotherapeutic drugs, to coincident drug like the anti-infective drugs, and others. The allergic interstitial nephritis, the crystal nephropathy, don't miss it, the osmotic diuresis nephrosis secondary to high osmotic load like the IVIG, the mannitol, The thrombotic microangiopathy, which is common with a lot of chemotherapeutic agents, and the myeloma-related kidney disease, وهنتكلم عليها دي لوحدها. And the post-renal causes, and this is a common lesions leading to these post-renal causes. Don't miss the hemorrhagic cystitis with cyclophosphamide. Don't miss the retroperitoneal disease with metastasis and lymphadenopathy and others. So your patients, as I said, are commonly affected with AKI, especially with these 4 types of cancers. And I would like best to share you this catastrophic multiple myeloma and AKI, ودي الحقيقة it is a common between us and hematologists as well as oncologists. فده دمه متفرق بين القبائل، فاحنا بنشوفه دايما معاهم. Back again to the diagnosis of multiple myeloma, which you couldn't diagnose multiple myeloma except when you find this malignant clone plasma cell in the bone marrow, not the peripheral blood, in more than 10%, or monoclonal protein more than 3 grams per deciliter, plus one of the CRAP, calcemia, C for calcemia, R for renal impairment, A for anemia, and B for bony lesions. What are the causes of AKI among multiple myeloma? It's not only the cast nephropathy and light chain deposition disease, but the light chain amyloidosis, the hypercalcemia and hyperuricemia, the ATN from sepsis, and nephrotoxicity of the drugs also share in this pathology. And this figure الحقيقة كان لطيف إن هو مبين not only the glomerular disease with all these lists can occur in multiple myeloma, but others tubular lesions as proximal tubulopathy and cast nephropathy also share in these pathogenesis. The initial management first is the saline hydration, well hydration of your patient, correction of the hypercalcemia, the alkalinization of urine, beside the avoidance of any nephrotoxic agents in those patients. And the definite drugs, the definite management is the use of the chemotherapy beside the hematopoietic stem cell transplantation, وده له قصة مع ال AKI مش هندخل في تفاصيلها. And come also the extended daily dialysis using the high cut of fibers, filters to decrease the circulating load of the monoclonal light chains. طلع لها ايجو كده شوية وبتهدى وتوطى كده يعني I'm not so convinced with this issue. طيب what are the emergency occurring زي ما دكتور ناجي قال لنا نحضر what are the emergency. There are a lot of hemodynamic changes, lot of metabolic changes, and lot of mechanical disturbance occurring in those patients. Among these, the sepsis, which is quite common, and it causes AKI by multiple factors مش هنتكلم فيها دلوقتي. Another catastrophic also situation is a contrast, and common as well, is the contrast-induced nephropathy, which are commonly among those patients. So take care if you'd like to give your patient a contrast in those situations, in CKD, in diabetic patients, in volume depleted patients, when you could administer nephrotoxins, when you use these contrasts arterially, not venously, and if you have to use a high osmolality contrast material. So take care in this situation. Your patient is prone to have this AKI secondary to the contrast. And the prevention is much easier than the treatment, because you can advise the radiologist to limit the contrast volume, to use the high isoosmolar as he can, with prehydration of the patient, and stopping any nephrotoxic agents beside the N-acetylcysteine and bicarbonate, which is somewhat debatable, and the hemodiazepine and hemofiltration, which is also debatable. The tumor lysis syndrome is quite common, so take care if your patient is taking chemotherapeutic agents and the tumor is large or fast growing and chemosensitive as well. So you are expecting a break, a lysis of this load of malignant cell with the sequelae of the release of intracellular content, and the most dangerous is the uric acid with its problem in making this syndrome, beside the hyperphosphatemia, the hyperkalemia, and the hypocalcemia. So the mechanism is not only urate nephropathy, but also phosphate nephropathy share in this pathogenesis. And the prevention is easy by well hydration and taking any of the xanthine oxidase inhibitor, but the treatment is somewhat difficult, and the rasburicase اللي مش موجود عندنا في مصر is the only effective agent, and the hemodialysis هو اللي في ايدنا. The hypercalcemia of malignancy is quite common to occur in 1/3 of our patients, and it is common in squamous cell carcinoma of lung, adenocarcinoma, hematological malignancy. The mechanism is too many, and the treatment is mainly the well hydration of your patient, the loop diuretic, the hemodialysis, the bisphosphonate, and this denosumab, which is a monoclonal antibody neutralizing the receptor activator of the NFK beta ligand, so as to reduce the bone calcium release. The hematopoietic cell transplant له issue كبير، فمش هندخل في تفصيل عشان الوقت، بس ضروري نبقى عارفين ان في كل ستيج منه له كوزس. في البري انجرافتنج ستيج those who are يعني اللي حضراتكم مهتمين بالانكونيفرولوجي مع those في البون مارو ترانسبلانتيشن او في الهيماتوبويتيك سيل ترانسبلانتيشن هيعرف ان الاي كي اي في البري انجرافتنج ستيج له اسباب، في الانجرافتمنت ستيج له اسباب، فالوقت بس مش ساعفنا. The abdominal compartmental syndrome, don't miss it. When your intra-arterial pressure of your patient is more than 10 millimeter mercury with organ dysfunction, mainly hepatic and renal. So you have to anticipate this syndrome. And the cause are malignant ascites, urological operation with urine leak, colonic dilatation, and the treatment is treatment of the cause. The chemotherapeutic nephrotoxicity may affect any part of your nephron, so take care of your patient while he's taking any of these chemotherapeutic agents. نبص على any chemotherapeutic agent، ونبص على السينرجيزم اللي بيحصل مع بعضهم البعض. يعني ممكن هو ده لوحده مش كفايه وده لوحده مش كفايه، انما لما تاخدوا مع بعض يبقى في synergistic effect. These are some monoclonal antibodies that used in those يعني as a chemotherapeutic agents or as adjuvant drugs with your patients. ما تهيأليش ان في وقت، بس انا همشيهم بسرعة كده just names. conclude by this conclusion that emergencies in onconephrology are too many, and nephrologist is an important member of the oncology team. Multiple renal problems may occur with cancer patients, and AKI is the most dramatic renal complication occurring with malignant patient. And thank you very much.